We're going to start by going through definitions very quickly. First one is codominance. Codominance means multiple alleles that are expressed simultaneously. For example, blood group, which can be either A, B, or nothing. Variable expression is an example of the same allele in different people, which presents with different severity. Penetrance is similar to variable expression. It means that if an allele is present, it may or may not actually cause disease. For example, the breast cancer 2 gene, meaning the BRCA mutation, it is a risk factor for breast cancer. It's not a guarantee of getting breast cancer. Pleiotropy is the effect that a single gene may have on various phenotypical parts of a presentation. For example, the cystic fibrosis mutation is just a single gene, and yet it causes respiratory infections, salty sweat, and pancreatic insufficiency. So various expressions from a single gene. Imprinting. Now, imprinting is a little bit complicated, so we're going to try to explain it. Imprinting is a type of gene in which only one locus is actively transcribed, and the other one is inactivated by methylation. The deletion of the normally active allele causes disease. Now, specifically with imprinting, it depends on which gene you get from which parent. And we're going to talk a little bit more about that in a few minutes in the context of Angelman syndrome and Prader-Willi. Anticipation describes that the severity and the onset of a disease gets worse and earlier as the disease passes down into future generations. Loss of heterozygosity. Let's say that somebody is heterozygous for a trait for a disease. In other words, it's a recessive disease, so if you've got one normal copy of the gene, you don't necessarily get the disease. Now, let's say I get a cell that suddenly loses the normal copy of the gene. Then all that's left is the diseased copy, and suddenly that cell is going to display the disease. And that's going to be especially important for cases that have something along the lines of an oncogene or a tumor suppressor. And those can turn into cancer even if only one cell starts to show signs of having a problem. A dominant negative effect. Let's talk about that. So usually one normal copy of an enzyme or protein may be enough for a normal phenotype. We've been saying that already a couple times. But sometimes the mutation, which is found only in one copy, leads to an abnormal protein that actually inactivates the other normal protein. An example would be P53, which is, very important tumor suppressor gene. P53 works by hybridizing into a dimer. So two P53 molecules come together. So let's say I have one normal P53 and one abnormal P53. If the abnormal P53 has a mutation at the site where they bind together, then the dimer is going to be inactive. So in this case, the negative mutation is enough to cause a dominant effect. And that's different from just having a deletion of one P53 gene, because I still have another one which can make normal P53, in which case my cells won't show signs of disease. But the dominant negative is a particular kind of mutation, which actually effectively the bad protein knocks out the good protein. Linkage disequilibrium. So when we studied Mendel genetics, the beginning of medical school and even in college before that, we learned about random assortment. But remember that genes are on chromosomes, so therefore genes that are near each other on chromosomes are likely to be passed down together through inheritance. So linkage disequilibrium just means that genes are passed in patterns that seem to be linked together, and the normal Mendelian equilibrium is sort of disrupted as a result. Mosaicism describes different cell lines that are present in the same body. So for example, the normal egg is fertilized with a normal sperm, and you get a 46XX zygote, for example. Then, before we reach the morula stage, we only have a couple cells. So what happens if, like, the first division, one of those cells loses an X chromosome during an error in mitosis? Then pretty early on, we're going to have one cell line, which is normal, with 46XX karyotype, and the other one, which is abnormal, with 45XO. And this baby, as it grows, it will have a presentation that's similar to Turner syndrome, but the exact presentation will vary depending on which cell lines are affected. Locus heterogeneity describes different loci that can cause the same symptoms. For example, Marfan syndrome is a problem of fibrillin, whereas Ehlers-Danlos is a problem relating to collagen, but they both have very similar presentation. Uniparental disomy is a situation in which both copies of a chromosome come from a single parent. In other words, a recessive disease that, mom is a carrier for, but dad does not have, can still be expressed if, for whatever reason, both diseased alleles came from mom during the fertilization of the egg. Now let's talk a little bit about Hardy-Weinberg equilibrium. Hardy-Weinberg equilibrium is used to describe a situation in which two alleles exist for a particular trait. So let's say we call the normal allele P and the diseased allele Q. Then, in general, it's either all normal or all diseased. So we say P plus Q equals 1. Now, that's true for a single chromosome. What if we take into account the fact that there are two chromosomes? Well, we still have a similar equation, but we really need to square both sides of this equation so that we have, it accounts for two chromosomes. In other words, we have the new equation, which is P squared plus 2PQ plus Q squared. In this case, P squared represents the frequency of homozygous normal. Q squared represents the frequency of homozygous disease. And the 2PQ represents the frequency of the heterozygous type of genotype. Now, Hardy-Weinberg equilibrium in general has got a bunch of rules, but we're just going to sum it up by saying it assumes that there's no overall change to the population genetics. And that includes no mutations, no natural selection, no migration, etc. Let's talk a little bit more about imprinting for a moment, because we're going to bring it up in the context of two diseases, Prader-Willi and Engelmann syndrome. So Prader-Willi is caused by the loss of the normally functional paternal allele. So Prader-Willi, it starts with the P, and that's for paternal allele. And Engelmann syndrome has got the M in Engelmann, and that's caused by the deletion of a normally functional maternal allele. They're both diseases caused by loss of the chromosome 15. Prader-Willi presents with hyperphagia. That's the key thing. You'll also have mental retardation and, short stature or something like that. But the key thing is going to be the child that just eats everything that he can get his hands on, or she. Engelmann syndrome is going to present primarily with seizures, as well as being overly friendly and having periods of inappropriate laughter. So these children are typically called, somewhat inappropriately, happy puppets. Let's talk a little bit about how they are transmitted, and that's really going to get us into a little bit more about other kinds of diseases. So we're really going to talk specifically about pedigrees and how you should recognize these modes of inheritance. Now, when you're looking at a pedigree, assume that people marrying into the family are normal. That's a general good practice. So when you're looking for a pedigree that shows an autosomal dominant mode of inheritance, you'll see the disease in every generation affecting both males and females equally. If it's autosomal recessive, you should expect to see the disease skipping generations, also affecting both sexes approximately equally. X-linked recessive, you'll see pretty much only males affected. Rarely you'll see a girl, but for the most part only males, and you will never ever see male-to-male transmission. The diseased males in an X-linked recessive pedigree are always going to be getting the disease from an unaffected female, meaning if you track which people are carriers for disease, they're always going to be unaffected women having babies that are affected, that are boys. X-linked dominant is a little bit different. It's usually only girls that are affected. Why? Because it's normally so severe in boys that it kills them. It's rarely seen on the test, so you're actually unlikely to come across that one. And mitochondrial pattern of inheritance, it's only transmitted from a woman to every single one of her children. They all get the disease. It's also very rare on the test, so you're unlikely to see it. So now we're just going to go through a crash course in genetic diseases. We're really going to be blazing through these. It's too many to spend a lot of time on it. We're really going to take note only the key features, in particular, the pattern of inheritance, which chromosome might be involved, what symptoms, what complications there are, and what treatment, if there's any. As a general rule, I'll just say this. If it affects only boys, then think X-linked recessive, and that includes things like color blindness and Lesch-Nyhan disease. If the mutation is in an enzyme, then your chances are that the pattern of inheritance is going to be autosomal recessive. It's not always true, but it's a good rule of thumb. The reason is that for an enzyme, as long as you've got one good copy, the cells can normally function properly. If the mutation is in a structural protein, or an oncogene, or a tumor suppressor, then the likelihood is that it's an autosomal dominant pattern of inheritance, and the reason is that just one bad copy is enough to cause the disease. So we're going to go through a list of autosomal dominant. So all these diseases I'm going to mention now are all passed down autosomal dominant. First one is achondroplasia, also known as dwarfism. It's caused by a loss of the fibroblast growth factor, receptor number 3. It's also associated with having a father that's old when he fertilizes the egg and basically when the child is born. The next one is adult polycystic kidney disease, also known as autosomal dominant polycystic kidney disease. It causes bilateral massive polycystic kidneys. It involves chromosome number 16. It presents with hematuria, flank pain, end-stage renal disease ultimately. It presents primarily later on in life. It's associated with polycystic liver as well as mitral valve prolapse and berry aneurysms. So anytime you see something like berry aneurysms, you should be very, very suspicious about that on the step 1. They like to test that. Next is familial adenomatous polyposis. This causes lots of colon polyps that form only after puberty, and it's a very high risk for colon cancer. And pretty much the only way to prevent colon cancer is to cut out the colon. It's caused by a deletion of the APC gene that stands for adenomatous polyposis coli. It's on chromosome number 5. The APC gene is a tumor suppressor. Next is familial hyperlipidemia type 2A. It's caused by the loss of an LDL receptor. And what happens is the liver can't pick up LDL molecules. Peripheral tissues as well can't pick up LDL molecules. And what you'll find is that people have LDLs over 300, which leads to severely accelerated atherosclerosis, xanthomas on their Achilles tendon, which are basically yellow plaques, which are deposition of cholesterol molecules, as well as early MI and stroke. Next is hereditary hemorrhagic telangiectasia, also known as Osler-Weber-Rendu syndrome. In this case, it's a disease of blood vessels which leads to telangiectasias throughout the body, which are nothing more than overgrowths of capillaries. It causes bleeding and arteriovenous malformations. Next, we're going to talk about spherocytosis. It's caused by the loss of either spectrin or ankyrin gene. These are both important structural proteins that give the red blood cell its characteristic biconcave shape. So if you lose either one of these proteins, you end up having a loss of that biconcave shape. It's normal, spherical kind of shape, and that causes a hemolytic anemia because the macrophages in the spleen basically just eat up these cells. And the only treatment is a splenectomy. And after splenectomy, of course, you have to worry about all the associated complications to the splenectomy, one of which requires prophylactic antibiotics for the rest of the person's life. Huntington's disease is another autosomal dominant disease, which is caused by a trinucleotide repeat expansion. In particular, it's the CAG repeat CAG, which is found on chromosome 4. More repeats means earlier presentation and a worse disease progression with a more poor prognosis. Less than 30 repeats in the gene is normal, and then what happens is that the expansion is pretty rapid. It goes basically from 30 to about 100, pretty much nothing in between those. The onset is somewhere between 20 and 50, and the onset varies somewhat with how many copies there are of the CAG repeat. It presents primarily with personality changes leading to dementia. Later on, you see the characteristic choreiform movement, choreiform meaning appears to be dancing. Ultimately, it goes to progressive deterioration and death. It's also associated with decreased GABA transmission and atrophy of the caudate nucleus with corresponding ventricular enlargement on pathologic specimen of the brain. Marfan's disease we've already introduced. It's a mutation in the gene for fibrillin. It causes a tall, lanky kind of body habitus. They have long extremities and fingers. They can have pectus excavatum and cystic medial necrosis of the aorta, which leads to aortic dissection as well as aortic insufficiency and mitral valve regurg. Multiple endocrine neoplasia, there's 3 types. Type 1, I think of as being the 3 Ps. It's cancers of the pituitary, pancreas, and parathyroid. Class 2A is the parathyroid, medullary thyroid cancer, and pheochromocytoma. And class 2B is medullary thyroid cancer, pheochromocytoma, and neuromas. Next is neurofibromatosis number 1. It's also known as von Recklinghausen's disease. It involves chromosome number 17. Neurofibromas number 1 gene inhibits the RAS oncogene. So a deletion of NF1 causes sort of this oncogenic sort of overgrowth of tissues, including cafe au lait spots of pigment on the body, neurofibromas, which are benign growths of nerve tissue, and Lisch nodules, which are hamartomas of tissue in the iris in the eye. And you're going to see those really only on slit lamp exams. So don't expect to look at somebody who's got neurofibromatosis number 1 and actually see the Ehrlich nodules. They also have increased risk of optic gliomas and pheochromocytomas. Neurofibromas number 2 is on chromosome number 22. So NF2 goes to chromosome 22. It causes acoustic neuromas, also known as schwannomas, and cataracts. Note, there are no neurofibromas in NF2, at least not for the purposes of step 1. In real life, they may have them too, but you're not going to see that. If they do not have neurofibromas, but they have acoustic neuromas and cataracts, it's NF2. Tuberous sclerosis. Don't confuse this one with neurofibromatosis. That was always tricky for me. I kind of mixed them up. Tuberous sclerosis number 1 has incomplete penetrance and a variable presentation, so that's important to know. So what can it have? Keep in mind that there's no real specific presentation. It can have facial lesions. Classically, there will be ash leaf spots, which are plaques of skin on the body that are hypopigmented, so they're lighter than normal. You can also have cortical and renal hamartomas, meaning growths in the brain, and that can cause seizures, which is one of the most common presenting complaints of tuberous sclerosis. It can cause mental retardation, renal cysts, and angiomyolipomas, which are tumors of blood vessels. That's angio. Myo means muscle, and lipomas are clear cells, like adipose cells. It's also associated with increased risk of cardiac rhabdomyomas and astrocytomas. And the thing that I remember is just WTF, dude. It's a great mnemonic. WTF stands for white is tuberous, meaning the skin lesion is the white one, the hypopigmented one, goes to tuberous sclerosis. Whereas if you see somebody with fibromas, that's the F, then you expect to see the dark skin lesions. So WTF, dude, is WTFD. White is tuberous, fibromas goes with dark. Lastly, for autosomal dominant, we're going to talk about von Hippel-Lindau disease. It's caused by deletion of the VHL gene on chromosome number 3. This is a tumor suppressor which stops angiogenesis. That leads to hemangioblastomas of the retina, cerebellum, medulla of the brain, and it's also associated with increased risk of renal cell carcinoma. So beware of seeing clear cells on a pathologic specimen of a tumor in the kidney. So now we're going to get into autosomal recessive diseases. This includes albinism, autosomal recessive polycystic kidney, which is also known as pediatric polycystic kidney, cystic fibrosis, various glycogen storage diseases, hemochromatosis, the mucopolysaccharidoses, phenylketonuria, sickle cell disease, the sphingolipidoses, and thalassemias. So when we talk about cystic fibrosis, we need to know that it's caused by the loss of a chloride channel, which is the CFTR gene on chromosome 7. The most common deletion, which you're likely to be tested on the step 1, is the deletion of the phenylalanine in the 508 position. It's also known as delta F508. It causes 2 different main kinds of problems. Number 1 is in the lungs. The chloride channel, it normally is used to pump chloride into the alveoli. Loss of this channel makes it impossible to move sodium chloride into the alveoli. Remember, sodium follows chloride just for the sake of charge balance. And water will always follow osmoles. So if you can't move sodium chloride into the alveoli, you can't move water into it. And what ends up happening is that you cannot sort of solubilize the stuff that's in the lungs. This leads to consolidations, pneumonia, in particular Staph aureus and Pseudomonas pneumonia, ultimately bronchiectasis, etc. This is true also of the pancreas. You can't pump sodium chloride into the ducts, so you can't solubilize the pancreatic enzymes. This ultimately causes clogging of the pancreatic duct and pancreatic insufficiency, leading to a malabsorption syndrome. And you also have some autodigestion of the pancreatic tissue, which causes pancreatic damage and leads to insufficiency of the endocrine function of the pancreas, leading to diabetes as well. On the other hand, in the sweat glands, sweat is formed as an ultrafiltrative plasma. So what the chloride channel is doing in the sweat gland is it's actually reclaiming chloride. So what it normally does is it's used to dilute the sweat. So loss of this function means you're going to end up having excessively salty sweat, which we know about. That's why you have the salt test for babies suspected for having cystic fibrosis. Now, the treatment for cystic fibrosis is going to be N-acetylcysteine. It helps to break up the mucus in the chest. You can also give antibiotics, of course, for pulmonary infections, and chest physiotherapy helps break up the consolidated mucus in the lungs. Next, we're going to talk a little bit about X-linked recessive disease. This includes Bruton's agamma-globulinemia, which is the mutation of the B-cell tyrosine kinase, Wiskott-Aldrich syndrome, which presents primarily as the triad of eczema, low platelets, and immunodeficiency, Fabry's disease, which is one of the sphingolipidoses, which we're going to talk about later on in this review. G6PD deficiency, or glucose 6-phosphate dehydrogenase deficiency, which causes hemolytic anemia under oxidative stress, as well as ocular albinism, which is albinism in the eye only, Leishman disease, Duchenne's and Becker's muscular dystrophies, Hunter's disease, hemophilia A and B, which are deficiencies of clotting factors 8 and 9, respectively. Let's talk first about the muscular dystrophies. Both Becker's and Duchenne's are related to mutations in the dystrophin gene, which is a protein which binds the cytoskeleton to the contractile proteins in the muscle cells. This causes a loss of the muscle cell to be able to coordinate contraction. It also causes myocyte death, which will be noted as a rise in creatine kinase in the blood. You also have scarring of the muscle, which leads to atrophy in the body and pseudohypertrophy of the calf muscle. In Duchenne's disease, we see in particular a severe form of the disease. It's due to a complete deletion of dystrophin, secondary to a frameshift mutation, which causes an early stop codon. What you're going to see is proximal muscle weakness, which leads to Gower's maneuver, which is a child who braces his hands on his knees to help himself stand up. We'll see calf pseudohypertrophy and cardiomyopathy. The presentation is usually less than 5 years of age. Becker's muscular dystrophy, on the other hand, is a less severe form. Its onset is early in adulthood, and it's better prognosis. Let's introduce quickly the trinucleotide repeat expansion diseases. We already mentioned Huntington's, which is a CAG repeat on chromosome 4. Myotonic dystrophy is repeat of CTG on chromosome 19. Basically presents as muscular dystrophy with myotonia. Myotonia means slow or incomplete muscular relaxation. It also presents with neurologic problems, in particular delayed development, low intelligence, and behavioral problems. Fragile X is caused by a CGG repeat on the X chromosome. It causes a fragile-looking X, like it looks like it's broken. That's how it's named. It's the second most common genetic cause of mental retardation behind Down syndrome. So in particular, it causes mental retardation. It causes large testicles, big ears, a big jaw. It's associated with autism and mitral valve prolapse as well. Lastly, we're going to mention Friedreich's ataxia. It's caused by the trinucleotide expansion of GAA on chromosome 9. It causes a loss of neurons in the spinocerebellar and dorsal columns, as well as the corticospinal tracts, leading to a very particular type of ataxia. We're going to quickly go through the major trisomies. What do you need to know? You need to know these three, and they go in order of most common to least common. That's Down syndrome, which is trisomy 21, Edwards syndrome, which is trisomy 18, and Patau syndrome, which is trisomy 13. So Down syndrome is noted to cause mental retardation, a very particular kind of facies, which includes a flat face and epicanthal folds on the eyes, as well as simian crease of the hands. And we see a picture over here of the hand with a simian crease. It's associated also with various congenital malformations, including duodenal atresia, heart defects, especially those involving the endocardial cushion tissue, for example, AV canal. There's increased risk of acute lymphoblastic leukemia in childhood, as well as early onset Alzheimer's a little bit later in life. What happens is that during pregnancy, all women are screened when they're followed by their obstetrician for the quad screen. And what we'll find if there's trisomy 21, there will be elevated beta-HCG and inhibin. On the other hand, a abnormally low alpha-fetoprotein and estriol. And you'll learn more about this quad screen test next year when you're on your OBGYN rotation. It's most common due to non-disjunction during meiosis, especially in women of advancing age when they become pregnant. Edwards syndrome causes mental retardation, rocker bottom feet, which means that their feet literally looks like the bottom of a rocking chair. They also have characteristically clenched hands and heart disease, and usually it kills the child by the time they reach 1 year of age. Patau syndrome is an extremely severe disease. It causes midline defects, in particular cleft lip, hollow prosencephaly, and cyclopia, and usually this kills the baby by also 1 year of age. Let's talk about some chromosomal involvements. A Robertsonian translocation. This involves a translocation of genetic material between acrocentric chromosomes. Those are those really little tiny chromosomes, which include chromosomes number 13, 14, 15, 21, and 22. A balanced Robertsonian translocation, meaning that the normal amount of genetic material is still preserved, causes no problem because you still have the normal proteins in place and all normal regulation is still in place. An unbalanced problem looks like something which resembles trisomy or monosomy, depending on whether there is the gain of extra genetic material or loss of extra genetic material. Chromosomal inversions basically happens when a chromosome flips part of its DNA upside down. Now, a pericentric inversion actually involves a centromere. So what this means is that this cell can still undergo mitosis because the centromere is still there. It can still connect to the spindle and reproduce that way. Paracentric inversion does not contain the centromere, and therefore it cannot connect to the mitotic spindle and therefore cannot progress that way. We're going to quickly mention a couple other diseases and then close the lecture. Cri du chat literally means cry of the cat. It's caused by a microdeletion of the short arm of chromosome 5. It causes mental retardation and a very characteristic facies, including epicanthal folds. It also causes cardiac abnormalities and a very characteristic high-pitched crying, which sounds like the mewing of a cat. Williams disease is caused by deletion of the long arm of chromosome 7, which contains elastin. This causes mental retardation, very characteristic elfin type of facies. It also causes hypercalcemia. They behaviorally are overly friendly, and there are also cardiovascular problems. There is another group of deletion diseases called the 22q11 deletions. They may present various sort of presentations, including cleft palate, abnormal facies, thymic aplasia, which leads to severe combined immunodeficiency, cardiac defects, and hypocalcemia secondary to the loss of the parathyroid glands. So this includes DeGeorge syndrome, which is a loss of the third and fourth branchial pouches, which causes agenesis of the thymus and parathyroids, as well as cardiac disease. There's also velocardiofacial syndrome, which involves the palate, the facial malformation, and cardiac malformation, and that's where the name velocardiofacial comes from.